All right. So my team, myself, on left side, Dr. Khera was there. He's a director of structural program at Mount Sinai here. And other on the right side is our fellow. We actually have 3 interventional fellows at present. And Amjad Khurana from India. And so program continues to grow. Actually, 3, maybe even 4 we need. So let's show the case number 2. We just showed the case of the mitral tear, and this is the case for the tower. So this is the patient, basically 68-year-old, has multiple issues in terms of cardiac, had risk factors, then had a bypass surgery, had some PCI, but continues to have symptoms from severe aortic stenosis. And that's where he is now with a severe calcific trileaflet, although age is 68. And they have been progressing with the AS for last 8-10 years and has kind of a paradoxical low flow, low gradient, severe aortic stenosis. And the cath-wise, things were okay. So in this particular case, if we go to echo, and actually rather than show here, I would say that we should go live with the stem Laracus on the echo side to show that how significant this aortic stenosis is. So let's show the echo, please, live echo now.
Yes, thank you, Dr. Sharma. We are live.
Wait 1 second. No, we are not live yet. Can you hear us?
We hear you fine. Yeah, we're waiting for the echo to switch.
Yeah.
Awesome. Yeah. Okay, let's switch to echo, please. They can hear us.
I think they're taking a little time to get to the switch. So let me just quickly present so far from aortic stenosis point of view. And then this patient has a tower CT with the appropriate. So I think that what happened is the mic issues are, turns out to be there limited mics in the room. And that's a not right thing to do. But anyway, so, and they cannot bring the, can we guys get the actual echo on the screen now? Yeah, good. Okay.
Go
ahead, Sam. You go ahead now. Yeah.
Yes. Thank you. Good morning. As you can see, the LV function is normal. The ventricle is thick, small ventricle. You can see here the mid-esophageal view, normal LV function, thickened ventricle, thickened mitral leaflets with mild mitral regurgitation.
Stan, maybe you could be a little louder. I don't know whether people are hearing downstairs.
The right ventricle looks normal, minimal tricuspid regurgitation. X-plane of the aortic valve, as you can see, thickened calcified aortic valve leaflets, tri-leaflet aortic valve, decreased excursion of the leaflets, mild aortic regurgitation. This is the deep gastric image. As you can see, thickened leaflets. You can appreciate the mild aortic regurgitation and the decreased mobility of the leaflets. Pressure half time about 410, so it's mild to moderate regurgitation by pressure half time. The peak gradient is 26, mean gradient 16, and the peak velocity 2.6 on the transthoracic echo. Before got a higher velocity about 3. The gradient, the mean gradient was about 25 on not anesthetized patient. And putting all together, aortic valve area 0.8, stroke volume index 21, so paradoxical low flow, low graded aortic stenosis with index aortic valve area of 0.4 centimeter per meter square. So D3 stage of aortic valve stenosis and disease, indication for TAVI on this symptomatic patient. Thank you.
Okay. So that question is, I think, could be the discussion point also. So this is the patient has a normal ejection fraction. We can go back to the CT analysis. The question is, how do you make a decision that is it truly the true aortic stenosis? And I know we go with the calcium score many times in those cases. And so any important point, any difference from the CT point of view?
No, I think CT looks in the annulus and LVOT view looks pretty benign here. But there is an issue. If you go forward, there's a next slide. Yeah, you see that RCA stent. Does everyone appreciate those pictures, please? There's an ostial RCA stent that's protruding outside. So it always makes it really tricky when you're trying to do balloon expanding or even self-expanding platforms. So that is one of the challenges in this case. But let's see how we do it, how we tackle it. The sinuses are pretty generous here. And any concerns from the audience? Maybe Sushil
From
is
our
sitting here,
panelists,
or-
yeah. So question is, this patient also has a graft to the RCA, which goes only to PDA.
Mhm.
The rest of the right coronary, which we had done the stent about 2-3 years ago, he did have some symptoms and about 60% ISR of the proximal RCA, which we left alone. But that does supply a big part of the right coronary with the RPL branches, although PDA has a separate graft. But whole question was still that we don't want to occlude the right coronary, and with the valve size and selection was dependent on whether you take up a 23 or 26 millimeter based on what is going to impinge the ostium. So that is where the selection came down, that we'll go to just below. And of course, femoral axis is completely fine. Arch anatomy is very tortuous. And so just to sum it up, and I'll give the mic to our team here with Anu and Gilbert. On this case, the plan is use a 26 millimeter SAPIEN with 3 cc extra, and largely because of the frame height, it doesn't touch the ostium of that protruding stent of the right coronary.
Can I ask a
Any
question?
concerns from the panelists? Yeah, go
Yeah,
ahead,
just
please.
ask a question if you would consider wiring that RCA just in case you squash that stent, just so you have an ability to, I mean, it's not going to be easy to get back in there, but just to maintain some kind of access to the RCA.
That's a very good question. I think we do have enough splay and enough distance from the annulus. I think we should be okay. That did cross our mind, that should we try to protect it, if you will. But it seems like we'll be okay to do it without protecting the RCA. And be really honest, getting
Not
back,
sinus, right?
it's
So
always hard. And sinuses are pretty generous. So that's why we chose 26 plus 3, instead of going for a 29.
Oh, yeah, I mean, I think the sinuses are big. I guess the sizing thing is the one thing I'm a little, I would sort of lean towards a 29 here. You don't, it's the tricuspid, not a ton of calcium, but I understand, and maybe you can explain to the audience sort of your thought process and, sizing. Obviously the sizing is about anchoring as well as seal. Do you have any concerns with 26 in that regard?
No, I think, Sushil, we should be okay here. We've published data on this before that, you can have slightly undersized but fully expanded valve, gives you good results, at least in the short term. And I think 29, the biggest issue we may have is its interaction with the RCA stent. And also remember the 29 has a bigger or a taller frame than a 26. And that was the whole thinking behind why we would want to go with a 26.
Yeah, we've treated anatomy up to around 580. The mean diameter we also look at very carefully, as Sahil mentioned earlier. This is less than 28 mean. So once it's 28, I agree with you, Sushil, we definitely need to go 29 for PVL. Also, the LVOT is smaller here, around 530. So we think that as long as you don't implant too high, it should seal properly, in terms of at least at the LVOT level. If the LVOT is bigger, I completely agree with you. We have no choice but to go with a
29.
commit to a 29.
Mhm.
And so if you do a 29, Sushil, or others in the panel, would you take volume out or you go nominal?
not sure.
I mean, I don't know
please.
Yoshi, what you think, but
Give me the
go
valve.
ahead, Yoshi.
No, I would go nominal. And I think even with 29, with that height of 19 millimeters of RCA, right? I think you can place it right below and you'll be okay. I'd probably go with 29, but the thought process is very interesting.
Yeah, no, I agree. I mean, I think there's not a ton of high-risk features with calcium, so I would do nominal as well with the 29. I think the risks of root injury, and when you look at the CT, there weren't any high-risk features, so I think that's, that would be sort of my thought process. I don't know, others' thoughts?
You think you'd miss the right coronary artery, Sushil?
So
You think you'd
Would you
miss
do
the
a
right
pre-BAV?
coronary artery
Yeah.
with the
Yeah, I
29?
think
You
sinuses
think
are
you'd be
big,
right
and
under it?
under it, yeah. If you could, you have those, the stent is a landmark too, you could also just position it
Right.
right at it,
angle.
right under
Right.
it, yeah.
You're not worried
Watch
about the
your
LVOT if you got to go a little lower?
There's not much calcium, so that was the reason,
Okay.
because no other high-risk features.
I was going to ask an echo question here. So you said the paradoxical low flow, low gradient, normally F, mean gradient 16. What mean gradient do you think you'll achieve? 8, 9? What do you expect?
Stam, you want to answer that question?
I mean,
What gradient are we aiming
the
for here?
Gradient, as I said, the gradient, now the person is sedated and everything, but it was about 25, before. Today, at this time, is about 16, but
Yeah, please.
yeah, hopefully less than 10 gradient, but definitely is severe stenosis, and the patient is symptomatic. So I think will
Where's the 1cc?
improve his symptoms. So
Okay, that's the 1cc here.
So, Sushil, do you routinely do double tap for all your SAPIEN cases nowadays with the Resilia?
We have not. I don't know what others do. Again, I try to stay up long for the first inflation, 5 seconds, and hope that it stays. If I see recoil, then I do go back.
No, same. It
Got it,
hasn't
got
been our practice to do it routinely, but we leave the
So
balloon
let's go
there and we
deeper,
try to
right?
evaluate the recoil, then go if we have to.
Only valve in valves, we
Go-
do double tap.
okay.
Go in
Yeah.
saying.
That's
No, no,
too deep.
too much.
Yeah. So you see how it's interacting with the
Yeah,
stent
yeah,
there,
the stand already.
Okay, let's take a picture here. Just do a cine to see what we're
Yeah,
dealing with.
I
Stab
think
deep
that'll-
approach, please.
Okay, 180.
Good.
Okay, off.
So we're just below the stand at the level. I would go a little bit deeper, no? Like what to say? Or,
I think it's gonna fully
Okay,
foreshorten. Remember,
all right.
it's +3, so
Okay. Less flex, huh?
That's
No
good.
flex.
That's good.
You want to keep the pigtail in?
Who took the pigtail?
Keep the pigtail
I
down?
did not.
No. Okay.
Okay, 180.
Slow. Go slow.
Go all the way.
Very nice.
Go all the way.
Very nice.
Good.
Good. Right below the stand. Okay, good. So this is
Keep
plus
pacing,
3.
keep pacing, keep pacing, keep pacing, keep pacing, keep pacing. Off.
Let's
it's very
recover.
difficult to inflate.
Everything looks good.
What was the pressure?
Pressure's coming back. Yeah, we're gonna double tap. I just want to take one picture, please.
Okay.
Go down on your balloon. There's a little bit of yeah. Good. Let's
Good.
take a picture, guys.
You ready?
Go ahead. Beautiful.
Good. Okay, so
All
we
right,
need to
let's
double
do
check.
one more.
Yep, you see. Yeah.
I
No, we
think
already did.
+3 should be okay.
I don't think there's space for that. No? You want one more?
No, I think we should be okay here. +3. Do a good inflation. Okay.
We could
You want to
not.
add one more?
The thing is.
Pacemaker guru, ready? Okay.
Okay, 180. Now already discussed. They're saying most people don't do it.
So you see, go look at the cine. See it expanded further. Look at that. Or maybe I'm using my imagination, but I hope the audience all see the appreciate there's a
Keep
bit of
pacing, keep pacing.
Too much dye was.
Good.
Okay,
Off pacer.
let's see. Okay, let's look at echo now.
I want to do hemodynamics here,
Yeah.
please.
So
Pull back.
we're done, or we might need to hit. Let's
No,
do
we're
that.
done.
Cannot
2
hit
hits.
in
I
the-
think we should be okay. Go ahead, Stam.
Yes.
It looks very good, actually. Fully expanded there.
Some,
Looks very
calamities.
stable.
So this, yeah.
To
Oh, yes.
Sushil's point,
No PVL. Wide open leaflets. Okay, take that. Let's go in the stomach.
So we were just talking about this double tap concept. I don't know, can the audience and the panelists appreciate the frame expansion the second time when Dr. Kinney inflated the valve
Definitely.
fluoroscopically? Maybe we can replay that for everyone.
Deep gastric.
so that's the first one,
Yeah. Yeah.
and that's your second
No
one.
PVL. No valvular AI.
But you saw the first time there was a bit
Right.
PVL, right?
Gradient,
Yes.
Yeah.
On entry.
Over here,
valve.
see this picture?
The gradient.
You can see it just below that. Yep.
Mean gradient of 3.
So we
Great.
published this
That's great.
before, one in jack intervention and one in CCI, just talking about this concept of less oversizing and flow, and be able to actually better expand. And we actually just had a paper out in J Sky showing that even with I wouldn't say overexpansion, I would say optimizing the expansion. The CT actually shows a more complete expansion of the valve in terms of the rather than underexpanded. So whether it's 23, 26, or even 20, the two of them, or even 20, actually a more full circular on post CT when we did the follow up than otherwise thought. Because people say, well, if you add 2-3 cc, are you going to expand beyond 26? Then it was not the case. It was actually just 26, maybe 26 and a half on the CT measurement. So that's why we believe that this concept, and certainly we don't disagree that if this RCA stent was not an issue, we probably would have gone at 29 minus.
Or if the LVOT was bigger.
But the LVOT, especially was bigger, but this LVOT is smaller, and also patient is only 70s, despite prior CABG from a lifetime management standpoint. I think this case will probably land itself more likely to be able to redo TAVR in the future, rather than if you, let's say, have a 29 valve, right up to the RCA ostium stent, then you have to kind of figure out how to put the second valve, and you're gonna have to put it deeper than the first one to be able to avoid the RCA obstruction.
Coronary flow normal on the right coronary.
Just going to do some hemodynamics here.
So we'll do some hemodynamics as well.
Okay, let's zero everything here.
You give this one.
Zero everything.
Give this back to him. Yeah.
Good. It's open. It's almost nothing there.
So I always say that echo usually 3 millimeters usually on angio. I mean, hemodynamic will be close to 0. It's actually with about, although we have 2 millimeter gradient here. That's what you had, STEM also 3, right?
3 mean gradient.
Okay, so I think if everybody's okay, I know that we are a little delay in terms of the lectures. We complete these 2 cases while we are getting ready with others. We can go resume the regular lectures and so. All right, Anita?
Excellent
Yes,
job,
thank
guys.
you.
Beautiful result. Thank you.
Very nice case.
Okay, thank you.